So this is going to be interactive. You know, you guys, I can fly through all the information, but please, if at any point in time you have questions on specific things or you want clarification, interrupt me and we'll go through some of these tasks. It's a lot of information in a small amount of time. And I try to touch on a lot of the different aspects of actually developing and implementing the simulation curriculum. Both from a processes standpoint and then some of the nitty gritty, like detailed information. And at the very end, I'll provide my information. So if you guys have any questions, please feel free to email me. I can give you resources, templates, you know, all that kind of stuff. So I'm Erica Zimmerman-Mabes. I'm assistant professor for the Division of Trauma and Acute Care Surgery at Medical College of Georgia. I'm one of the APDs, and I'm also director of simulation education for the surgery residency. So part of my niche in this whole world was identifying the need for the development of implementation of multidisciplinary trauma simulation. So that's what we'll be talking about today. I don't have anything to disclose. So the workshop objectives for today are to learn how to develop and implement a multidisciplinary trauma simulation curriculum across a variety of institutions. Learn how to prepare simulation pre-briefs and debriefs, recognize common pitfalls of multidisciplinary simulations, learn how to conduct the actual simulation activities, again, in both small and large scale learning environments. And then I'll touch on constructing a trauma bay to reflect the roles and positions. So ATLS is the nationally recognized standard for the trauma resuscitations, and as a level 1 trauma center, it's expected that we follow these standards. But we all know that across learning environments and academic institutions, there can be a variety of learners and rotating educational learners at different levels and experienced backgrounds come through. The trauma resuscitations can be loud and chaotic. And so we recognize that development and integration of a focused educational structure was critical to provide team training. We needed to improve team communication, facilitate resident educational and leadership growth amongst emergency medicine residents, as well as trauma surgery residents. And ultimately, the goals were to improve the quality of our patient care by improving the trauma resuscitations. So at our institution, a trauma resuscitation project steering committee was created to provide oversight and direction in establishing a process by which trauma resuscitations could be reviewed in a systematic fashion. One of the major focuses at that time was on the implementation of a video review process for process and performance improvement, and to create a process for that, something that is a discussion for another day, because the whole video review tool was a different project, but I'm happy to answer questions at any point in time on that later. One of the things our trauma leadership recognized was increasing in new issues with teamwork in the trauma bay arising, you know, leading to creation of a trauma team training task force. So the task force was comprised mostly of emergency medicine attendings and trauma surgery attendings. And the purpose was to identify specific needs to improve the trauma resuscitations and develop a process for how we could create a functional team training process between all the different disciplines working together. Key to this project was developing the team training, and that led to the development and implementation of the multidisciplinary training process. I ended up moving quickly into chair of this committee as clinical director of the simulation education, and so this is how we started working on all of these processes. And so I'm excited to be able to share this with you guys. And please, like I said, if at any point in time you have any questions, I'm more than happy to stop, interrupt, and answer them. So I don't know how many people are familiar with Kern's 6-step approach to curriculum development, but basically it's starting with problem identification, moving on to a targeted needs assessment, identifying goals and objectives for the curriculum, educational strategies, implementation of those educational strategies, and then finally evaluation and assessment. How are you going to get results from this? So the initial problem identification regarding challenges with trauma resuscitations was identified at our institution really by basically all the service providers in the emergency department. Nurses, residents, faculty, all noted that there were significant issues with communication and concerns with, you know, outcomes and resuscitation flow. So clearly we identified this general need. So then we performed a targeted needs assessment to identify specific issues perceived by the multiple specialties. So we created semi-structured questions addressing the following. So identification of areas perceived as important issues to address, perception on clarity of roles and responsibilities of trauma team members, the perception of communication within the trauma bay, and identification of concerns of issues regarding leadership roles within the trauma bay, overall teamwork perception during trauma resuscitations, both simple and complex resuscitations, and performance of the primary and secondary survey in an orderly manner, and then overall perception of patient care and identification of any topics that they felt were very important and needed to be addressed with trauma team training. So this led to the next step in the Kearns approach, which was identification of specific goals and assessments. So this is where I kind of break things down into phases and how we tackled these problems at our institution. So phase one was really looking at our actual institutional trauma resuscitation guidelines and having a collaborative effort in developing new guidelines or updated guidelines along with specific objectives. Oh, sorry, I don't know. Yeah, absolutely. So with and I'm happy if you guys want to send me an email, or I can collect all your emails and I can send you the PowerPoint and I can send you some of the templates that are going to be in this, so you just have everything. So first, institutional guidelines were updated, and this was a collaboration with emergency medicine, trauma surgery, ER nursing, and respiratory therapists. And I'll get to this later, but I think that was a critical part, had a critical part in getting buy-in from people. So really getting the collaboration, and it helped us fine-tune and tweak things that as a physician and attending, I didn't even recognize that we needed to provide clarification for the nursing on certain things. So these are the clear objectives: to develop leadership with clearly defined team leaders and good time management, improve cooperation and resource management, demonstrate clear communication and interactions between the team leaders and other members of the team, execute excellent assessment and decision-making, and then demonstrating situational awareness with unexpected findings. So I'm going to be showing some little excerpts from our actual resuscitation guidelines. So this is our figure in the guidelines that has our specific resuscitation role assignments. So they clearly identify with this figure the exact placement of each of the critical bedside members, and these are the only people who should be inside the trauma bay on patient arrival. The guidelines focus on a very granular breakdown of each individual role with clear descriptions on responsibilities for each member. We also did some trauma bay remodeling. Simultaneously, we implemented these floor signs that were color coordinated and corresponded to matching lead. And of note, the lead was super exciting and very much appreciated by the team members. It was really fun. I was an art and design major, and so for me, I was like, I majored in colors. And so this was really fun when I got some trauma grants to do this. And the purpose obviously was for safety of our trauma team members. And I'm not sure, I know everyone's from different institutions, but we were recognizing continued issues with lead walking away or not having enough lead in the trauma bay for the critical bedside team roles. And so what would happen is you would have a really bad level 1 trauma, everyone rushes in, 2 people have lead, you're doing chest tubes, you get the airway, you're getting x-rays, and people are running in and out of the room because there's not enough lead and they're trying not to get exposed. So this was great because not only did it provide better protection and support for the actual trauma team members, but it also gave them this sense of belonging and that like they were important to all of us. So it's all color coded. We had large and small sizes in every single role, and they're labeled specifically for adult trauma and then has their exact role. Also in the guidelines, we went through, exact breakdown, very granular breakdown of the trauma flow. So 0-point survey, this is where we're discussing, what's coming in, what are we anticipating, making sure we have expected equipment for procedures always available, going through the primary survey with a very detailed breakdown, plus or minus primary survey adjuncts, and then moving on to the secondary survey, emphasizing the importance of doing a debrief or a summary, and then moving on to the secondary survey. So phase 2 was the first set of interventions. And this is the guidelines orientation that we did perform with low fidelity simulations. So we did these orientations separately with surgery residents, emergency medicine residents, and nursing. And during all of these things, they had opportunities to ask questions, voice their concerns. And part of the reason yes, go ahead. I led all of them. Yeah, so a lot of work. So I led everything. So with the general surgery curriculum, with the general surgery residents, I led everything with the assistance of my surgical education PhD. With the emergency medicine, I led everything, but with faculty participation, so they were there and available. And then with nursing, the nursing guidelines, I went through everything again, but I had nursing leadership and the nursing educators present. So one of the things, you bring up a good point too. I think one of the things that we decided at the very beginning with the resuscitation committee was that having a single voice and keeping consistency across the board was critical, especially at this point of like this critical point of change and trying to implement big changes. Yes. Yeah, a little bit about yes, absolutely. So in terms of each different bedside member, yeah, so this is how I started off all these guidelines orientations, was going through a very granular breakdown of all the different roles, where they were expected to stand and exactly what they would do. So right here, this is our trauma resuscitation team. So we have trauma team leader, which is always usually one of our surgery residents. However, we're having more integration of emergency medicine residents working with our surgery residents. And so especially with some of our level 2 traumas, when we have dedicated emergency medicine residents, they have started integrating into the trauma team leader role. So part of the purpose of teaching these guidelines is that it doesn't really matter who you are. You should be able to filter into all of these roles if you know what the expectations and the role responsibilities are. So you have trauma team leader, and I'm going to show you I can just skip right here. So trauma team leaders at the foot of the bed leading their trauma resuscitations. And this does vary. This is for adult trauma resuscitation. So I'm actually now trying to translate this into a pediatric trauma resuscitation committee, which is definitely a little different, but with the same goals in mind to improve resuscitations and outcomes. Airway, at our institution, airway is always emergency medicine. And then obviously anesthesia can back them up if they need to. They respond to all level 1s. We have a circulating nurse on the left side. That's going to be opposite of the monitor. So if we're in a different room, we specified this, that if you're in a different room and everything's switched, then we switch the nurses. The primary nurse is going to be responsible for hooking the patient up to the monitor, is going to be getting the labs, making sure we have IV access. The circulating nurse is going to be more responsible for procedural stuff, helping get atrium set up, helping, place the NG tube, assisting with the intubations, getting the level 1 transfuser set up, even calling for help. So if they're like, hey, we need more than the 2 nurses plus the scribe, we need more help, that's their responsibility to reach out and say, hey, we need more people, as opposed to having all these people milling in and out. We're trying to really hone down, these are the 7 critical bedside members. RT is allowed to be there. That's for all level 1 traumas. And then we have our assessment and support physicians, and those can be filled by emergency medicine residents, general surgery residents. Sometimes we have medical students that fill especially the support. The assessment physician is going to be doing more of the procedures, and they just happen to be on the side where we have all of our trauma equipment. The support physician, that's where the ultrasound is. So they have it broken down that they are going to be in charge of doing the FAST, and then also assisting the primary nurse. If it's a chaotic situation, if we are short on nurses, that support physician will also help the primary nurse with getting the patient hooked up, helping apply supplemental oxygen, and so forth. So as we go through these guidelines orientation, again, this is just an example of a few slides example of how I gave the orientation presentation for these groups. We do go through, exactly position, foot of bed, roles and responsibilities. So the trauma team leader should be leading the 0-point survey prior to the patient arrival, anticipate any interventions, verbalize that with the staff. They're in charge of traffic control and quiet in the room. So they should be announcing quiet in the room, being a single speaker during the exam. And then it goes through all their exact roles. So ensure that the primary survey, adjuncts, interventions, procedures, and secondary survey are all performed appropriately in the correct order. We've been really focusing on this and in the correct order, making sure we complete the whole primary survey, including exposure, and especially in penetrating, but really with everything, and getting everyone on the same page. We've been emphasizing debriefing, making sure that they give summary of the important findings. Not only is it important for the entire team to understand what's going on, but it's important for the scribe and other people to just have that constant closed loop communication. So that's been a focus. At our institution, the TTL will either accompany the patient to the CT scanner, especially if it's a level 1 trauma, or making sure that they're delegating appropriately to have people go to the CT scanner and then communicating the findings to the trauma attending. And that may be the trauma attending's present, or they may be in the operating room, wherever they end up being at that time. So now I'll go through the actual guidelines orientation. So first we did the surgery resident orientation. And again, they had the opportunity to review the guidelines, ask about roles and responsibilities. Part of the reason we did this separately initially was knowing that specific groups had specific concerns that they might not speak up about if they knew everyone else was around. So we also did small group simulations. That this was performed in a very low fidelity setting. So this is something, even if you don't have a bunch of resources, you can have any old mannequin. You may or may not be able to intubate. We had one that we could intubate. Couldn't do anything else on it. We didn't have any other simulators in the room. But what I found this free app, it's called Simple. And it's this app where you can basically create, a monitor vital sign computer screen, and you can project that to a TV or an iPad and use it's a great visual key for the residents to see changes in clinical status with a trauma simulation. There's also a lot of resources. You don't have to make up every scenario on your own. You can Google and you can look for trauma simulations. And there's all kinds of templates and things out there that you can print off, things that are super detailed and complex, and others that are very simple. In this early stage, I use very, very simple simulation examples that were already out there. And then I just verbalized some of the changes and verbalized things to the group. And so again, free simulation app, minimal equipment, low fidelity, and it was a great opportunity for them to go through the process and the motion of the actual trauma resuscitation. Next, we did the emergency medicine orientation, and they have these formal education half days, and I was able to kind of slip into one of those days. And it was in this large learning space in the Interdisciplinary Simulation Center. So it started off as a lecture format, going through the guidelines PowerPoint again. And then we broke up into small group simulations, very similar to what we did before. And this was led by surgery attendings and residents. So I actually did the training of my surgery attendings and chief residents prior to this session. So everyone was on the same page. Everyone was comfortable with the simulations and how they would be executed, similar to how we had done the surgery resident. And then lastly, we did nursing guidelines. And this is a little bit different because, and we'll go into some of these challenges. It's difficult to get nursing to come and do a lot of continuing medical education things that's elective. And so we actually, I have night shifts and day shifts, and I personally started doing, an early morning shift or a later in the morning shift to make sure we captured the majority of the nurses. And so we just took opportunities when it was downtime at like 3 a.m. or 8 a.m. and it wasn't busy, and we could just grab the nurses. And we did a whole series of nursing guidelines orientation, and at that point, we just had this flat, they call it flat Stanley. It's basically just a trauma patient put on a big piece of paper, and that's what we used. So there was a couple cues that you could see, a couple injuries that the patient had, but then the nurses went through the motion and being in the correct positions.
So this was like an end of their shift or something like that?
So the nursing educators made it mandatory. So it was during their shift, and it was in the actual trauma bay. So at that point in time, we said, okay, we're pulling this group of people together, run through a simulation, pulling this group of people, run through a simulation, and reviewed the guidelines in their specific roles. So again, this is a whole nother topic discussion for another time, but simultaneously we were developing a trauma video review tool. And the structure of the tool, just in short, was basically, it matched right alongside our guidelines. So there's objective measures, based on primary survey components and secondary survey. But there were also subjective measures such as, was there a clearly defined team leader? Was there obvious cooperation? Was there, did it seem that it was performed in an orderly manner or a chaos? And we used Likert scales on these subjective measures, but actually narrowed it down to only a 3-point scale to try to minimize confounders. So moving into phase 3, and this is where we kind of get into the meat of the entire workshop, which, everything was all very important and integral in the development. But again, this is where we actually started doing the high fidelity multidisciplinary simulations. I'm gonna check on time. So, okay, we're good. So we ended up breaking down the curriculum and the individual sessions into these 5 sections. So we had a guidelines review. So even though we'd already oriented everyone, and we still do this with every single simulation, we sit down and go through the guidelines review, and we're on our 2nd year in doing this. We did a pre-brief for the simulation. We did the high fidelity simulation. Simultaneously, we broke into 2 groups. The group that was not doing the simulation would actually assess the simulation with our video review tool that we had created, and then a debrief session. So first, I'm going to talk about simulation case development. And it's one of the more lengthy processes that we noted, but I noticed that taking the time up front set me up for success. So I basically created a few stock simulation cases myself. And I'm going to go through some of the critical aspects of developing a case. So demographical and educational information, it's important to have your educational rationale, specific learning objectives, and then specific teaching and debriefing points. So this is just an educational rationale that we used. Development of multidisciplinary simulations is critical for the following objectives. And this goes back to those original objectives we talked about in terms of the actual updated guidelines. So our main focus now was not so much on the medical aspects and decision-making as much as it was the team communication and things being done in an orderly process. Now, your educational rationale and all these learning objectives can change over time depending on how you progress. So once you get to the point where like, hey, we've got team training down really well, this is excellent, then you can start moving into more of the clinical aspects. I tried to have specific learning objectives that were related to individual cases. So obviously performing primary and secondary survey is important. But I also, for example, this was a zone 2 penetrating neck trauma that I did. And so I wanted to make sure that they were able to identify hard signs of penetrating neck injuries, plan for difficult airways, recognize need for surgical airways, performing hemorrhage control in penetrating neck injuries. One of the trick things that I always did with this is the patient always came in, they were told, oh, it's a penetrating wound to the neck, and he comes in with a C-collar on, and so making sure that because half the time they're like going through everything and no one's taken off the C-collar, and starting to go through some of those things. Employing effective teamwork and communication, and recognizing the need for emergent surgical intervention. So primary teaching and debriefing points, of course, is critical, which ties into the specific learning objectives. And for this case, it was primary and secondary survey, evaluation of the penetrating neck trauma, difficult airway management review, hemorrhage control, appropriate resuscitation, and hemorrhagic shock. One of the things we find that's different is, my surgery residents and TTLs, they're very good about going to blood right away. We still have a lag in our emergency medicine residents wanting to give boluses of fluid. And we know, the trauma patient is like, if they're hypotensive, it's bleeding till proven otherwise. And so so having some of these discussions are really good with that. And then of course, the teamwork and communication. So with the case development, I like to add additional comprehensive learning and teaching points. And this is just for me to have everything all in one place so that moving forward, if we do tackle a bunch of things and we have extra time, or if we get to the point where they've mastered some of these skills, then I already have everything there already. I might have guided questions regarding, summarizing the zones of penetrating neck injuries and going through a lot more details. The second important thing about, simulation case development is making sure you identify, are you going to have a standardized patient, an actor, and making sure you have all of that clearly identified with the actor role, their script, specifications. This is how it looks on ours. We have, is it a standardized patient? Is it a nurse? Is it a family member? In ours, we had EMS personnel that would roll the patient in and be super disruptive and, oh, this is this guy, and oh, let me show you this picture of this car. And we're like, no, 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 let's get him moved over. So trying to, not that anyone's ever heard that yet. But actually we're trying to start integrating additional team members, but we started with the critical team members bedside before we started getting a little too fancy. Or maybe you have a simulation activity where you don't need any actors. General case information. So general case information is pretty broad, right? So it's good to have a general summary of a case scenario, especially once you start delegating other faculty members to do the simulation. So a lot of what I've done and a lot of this background is to create a scaffold that I'm going to be able to have my chiefs, my trauma fellows, hopefully a simulation fellow at some point, and colleagues be able to take these breakdowns and be able to do all of it. Obviously, HPI, past medical history, review of systems. A lot of the time with my trauma scenarios, I kind of skip a lot of that because they're unstable, and we don't go through all of that yet. But I will have the physical examination, and I have it in, clearly delineated between all the different areas. Diminished breath sounds on the right, chest x-ray has this, and I try to give more information than not. You can always cut it back, but at least if I have the information there, then it's less work for me to add later. Anticipated requests for imaging. And so this was interesting because you really have to start thinking, okay, well, what's the chest x-ray going to look like if they haven't done an intubation or a chest tube? What's the chest x-ray going to be if they intubated but no chest tube but no intubation? And so trying to figure out all those different areas, but just having everything. So I have PDFs of every single file. So it's just boom, boom, boom. Here's all the different possibilities, and it's all right there. Fast exams. So we're working on getting a nicer ultrasound. We've had a lot of glitches. I know some systems can use the fast ultrasound programs so that they can show them up, but we've had issues with our technology. So I found doing the same thing with chest x-rays and fast exams, just handing them the pictures once they ask them is the best. And then operations information. So, who's going to be actually running it for you? What's the room setup going to look like? What are the event logistics? What mannequin needs do you have? High fidelity, low fidelity? What kind of technology are you going to need? What additional equipment and supplies? And it may seem common sense, but when you have techs and support people helping, a lot of the time they don't think of all the things that you're thinking of as being critical. So we have this form, and like I said, I'm happy to send a template with all this information to you so you can see some of these things, but it goes through the room setup. Do you need a debrief room? Do you need a simulation room? Do you need a large group room for education? What kind of mannequin do you need? Adult, pediatric, standardized patient, low fidelity, high fidelity? Do you need the mannequin computer? Do you need to be able to use a microphone? Do you need to be able to be in another room? And I know we're all from varying backgrounds, so some people may have simulation centers that you can use this in and not. But if you do have a high fidelity simulation center and you can do this, having this all in writing is great for them. And then obviously mannequin setup and moulage. We also have a separate thing where it's like a picture of the mannequin and you can label how the mannequin could look. That may help for setup in a formal simulation center, or that may help if you have medical students or residents who can help get something set up for a session for people in the future. And then facilitator information. So you want to make sure as you're trying to move forward with the process that you can execute these state changes depending on the actions performed. And so this goes through very clear clinical state changes of, if the learner does this, then the facilitator does this. If the learner does this, the facilitator does this. Now, this may be state changes where you can just click on your, simulation software to go to the next state change. But some people find that confusing and tough. And especially if you're doing a low fidelity simulation, you're doing something just on the computer and you're changing the blood pressures and vitals on your phone. This is good for them to just have that as a guideline, and they can just quickly change these things. I've gotten to the point myself as the main simulator, it's faster for me to just click on the different things and change the vitals and change the clinical state than it is to have a single setup state. But I know some of the other people that I work with, they really liked having these exact labeled states. So as soon as something changes, boom, it goes to this next state and it's already in the simulation software. Also including facilitator notes. What particular tasks do the participants need to have completed? And then I find it really important to always include a debriefing plan. So that's where, group debriefing with an informal discussion to assess learners' performance and summarize key learning points. We utilize video review, and I'm going to show some pictures here in just a minute with our debriefing and observer debriefing. I also like to offer additional like potential debriefing topics. So for example, with the neck trauma case, evaluation and management of penetrating neck trauma, difficult airway management, hemorrhage control, teamwork communication, and professionalism. And so finally, this goes to the course director information. And this aspect is really, okay, how are we applying this on an institutional level? That like, who is this going to be important for? And so this is looking at the entrustable professional activities. Is it UME, ACGME competencies that we're evaluating, residency milestones that are addressed, a differential diagnosis and plan. And so you can really, a lot of these I'll actually break down and I'll include more and say, okay, it's patient care, patient evaluation, decision-making, all these different competencies that we're clearly touching on. And this is good from an institutional standpoint. So if you have this in writing and you have everything and you want to present it and you can say, this is why this is important, this is how this is applied. And we include medical students, we include our surgery residents and our, emergency medicine residents. And so that's been a really important thing to validate what we're doing. So now I'm just going to briefly go through our exact curriculum. So again, at the very beginning, we start off with it, and this is like a very relaxed, open environment. It's supposed to be a safe setting. It's outside of the emergency department. So that's supposed to, it does allow for, it's very low stakes. So we start off with the guidelines review, offer questions, opportunities to voice concerns. And then we pre-brief for the simulation activity. We start off pre-briefing for the activity in the actual room, going over, what are our expectations? What are we focusing on? What are the learning objectives? And right now at this standpoint, we've been focusing on communication, clearly defined roles, leadership, and so forth. And I make clear here, you're not going to be in trouble because you make the incorrect clinical decision. That's not what we're focusing on here. And that kind of lets them relax a little bit. The other thing that's really important about doing the trauma simulations is addressing your simulation space and pre-briefing about what's the space look like? How is this different than your typical trauma bay? For example, for us, we have a monitor that we can't cycle blood pressures on. So they come in and the patient automatically has an arterial line. So that changes, little things about the scenario. We have trainers. So we're moving into more higher fidelity mannequins, but right now we have trainers. So they have to, in this picture over to the right, you can see, sorry, your left. You can see that, we have these chest tube trainers and central line trainers, and you have to explain to them, if the trauma team leader tells you it's time to do a chest tube, you have to step away, perform the procedure here, and then go back. We've identified some things that are very disruptive. At the beginning, we tried to have the patient rolled in with EMS and transferred over. It was extremely disruptive and took a long time because the mannequins are heavy and you have to be careful with the cords. So we eliminated that. But going through where the drugs are, what it looks like, how you can administer drugs, pull up drugs, and so forth. Yes.
For the pre-brief, from the couple slides ago.
Yeah.
Is that just, by pre-brief, do they know what kind of scenario this is going to be, or just global expectations for what the simulation is supposed to achieve?
Yeah, that's a great question. And I do not give them information on what the exact case is. I do tell them it's going to be, so I tell them, you guys are going to go in the room. We identify the team members prior to going into the room and split them into two groups. So we have the one group that's going to be observing and evaluating, the other group who's going to be doing the simulation. And I explain to them, you'll put on PPE and you're going to hear overhead a trauma page. And that's it. Because unfortunately, that's frequently what we run into. We have no idea what's going on.
Yeah. Listing as opposed to go to, you know, but then they get like,
Yeah. Exactly. So in the low fidelity simulations, I'm like, you can't put a chest tube on them. You can't get IV access. You know, we have to verbalize these things. And same with like the intubation. Well, here's your airway cart. Here's your glide scope. And I may tell them sometimes they like get their glide scope and they're going to intubate. And then I'm like, you can't see anything. And the camera keeps getting splashed. Well, then they know at the top of the, code cart, they can grab the airway kit and get everything out. And that's been interesting in and of itself, realizing how much equipment I thought we had that we didn't, and then recognizing and just constantly adding more things to the simulation. Because the higher fidelity is, the more you realize when there's little things that are off. And so here you can see the group is actually performing the multidisciplinary trauma simulation on the top. There's this glass, you can see the mirror. I'm behind the mirror in the control room, so I'm controlling the mannequin, and I can also come over the intercom and tell them things. Sometimes the mannequins work great and everything's functioning. They have the pulse discrepancies I'm looking for. I can dilate their pupils. Sometimes everything shorts out and it's not working and you just have to run with it. So we'll talk about that a little bit with pitfalls. And then at the bottom, you can see, so we're really lucky to have this beautiful interdisciplinary simulation center, but the learners are actually able to watch the videos and we're able to record the videos so then we can review them in debriefing, but they're actually using our video review tool to assess all these objective and subjective measures of the performing group. So now we're going into phase 4, which is in situ simulation. So I was really fortunate. We had the State of Georgia Trauma Foundation provides grants, and we were able to get grants for 2 new high fidelity trauma mannequins that we're going to be starting to use in our actual trauma bays, doing in situ simulation soon. We're going through the process of learning the equipment, learning the mannequins, and then we'll translate that. But that's really exciting because it's taking the high fidelity to the next level. And eventually it's going to be paging it out as a level 1 trauma so that we see how long did it take for anesthesia to get there, ortho, and so forth. How long did it take to get to the CT scanner? So we just got the mannequins. We started doing training in April, well, this month. They just started doing training on it. So my hope, one of the things I learned with this process is I can want things to go as quickly as I want, but it's a slow process. So my goal is that by the fall, I would like to be doing the in situ simulations. The nice thing is with the in situ simulations, we already have trauma video review set up with cameras in all of our trauma bays. So even if the level 1 trauma bay isn't available, and we have a couple others that also have these floor indicator signs. So they're similar setups. They're like our backup level 1 trauma bay. Then we'll be able to do video review of those as well.
I guess I'm not what type of days we had our emergency physicians want to do it first thing in the morning. Since this is we don't
Yeah. So yeah, that's something we've had multiple discussions on. One of the things we talked about doing, similar to how we did nursing before, was doing one at like 3 or 4 o'clock in the morning. So the way we have our trauma attendings, there's always someone in-house from 7 to 7. So we have someone in-house, we're split up in shifts. So it's not like someone's sleeping and, they're being interrupted for this. Usually we're up all night long. So for us, we are able to accommodate doing it at 3 or 4 o'clock in the morning if things have died down, and it's a good opportunity. In terms of the daytime, that's something that's been discussed. They're like, oh, 7 o'clock. Well, 7 o'clock's shift change. Well, that doesn't work. Then once you get into like 8 and 9 o'clock, then surgeries are starting or rounds are going on. And so we're going to see how that ends up panning out. One of the discussions was 10 a.m. 10 a.m. seems to be a time where everything's shifted, sign-outs have occurred, people are able to address critical issues in terms of the operating room or rounding. We're fortunate that we have a group of 8, soon to be 9 physicians in our group. So a lot of the time there's someone on a different service or obligation that allows them time to do this. But yes, that's been a constant battle. The 3, 4 o'clock in the morning is very easy to say, oh, this is a good time. We'll do it at this time. But the morning time during the day shift is the struggle.
So what's the trauma?
The new one, the Da Vinci, the Leonardo. Yeah. And then I think we have a lower fidelity one, Apollo, who a lot of our EMS and outsourcing, and that's what we're going to be using for like rural community outreach with the Apollo.
How much do you feel like you push the residents along? Is there a lot of, like, if they're hesitant, you give them room to find out?
Yeah.
Extend it to like 40 minutes instead of
During
5?
actual traumas or during the simulations?
Yeah, actual trauma is different, but
Yeah.
during simulation, like how much do you give feedback? Pushing it?
Yeah, so it's a good point. So as I'm doing things, what I might do is I might come in and say, oh, he's really not able to breathe, and so I come up or come in with the patient and like the patient's totally unresponsive now. And so you get little cues. It is tough in the simulation setting because they're not getting those actual patient cues to try to move things along like that. And I notice with my senior residents, especially, this is like they're going into their 3rd year of doing this and teaching it and being part of it. They're pretty quick. It's the junior residents who are being TTL in a level 1 for the first time, or emergency medicine residents who a lot of the time don't have that same decision-making tree. Yeah.
That usually changes the kind of scenario. Kind of like take away. But yeah, how much time to give kind of get it, or
Well, a good point, even with like the declining patient, you'll have patients that have declined and you're like, all right, they're bradycardic and they're hypertensive. I told you there's pupillary discrepancies, what are we thinking? And sometimes people really struggle to go to the next step, even with the dinging monitors. And so at that point in time, I do step in and give them some sort of verbal cue to get them to the next step. And occasionally I have to say something like, do you want to call neurosurgery, or you want to give hypertonic saline? Like there's atropine in the code card. Again, my senior trauma residents are usually really good. I mean, I love their simulations. I'm like, I'm recording this. We're going to show this. This is fantastic. But some of the, a lot of the other ones are not so smooth. And especially, it's interesting to see that, the senior residents are pretty comfortable in the simulation at this point in time, but the junior residents and in some of the ER residents are still very uncomfortable in that trauma team leader role. But that's why this is good, because they find themselves in those trauma team leader roles and they're going to have to be able to do this. Otherwise, attendings and other people step in. So outcomes of the intervention, any other questions? Yes. Yes. So we're actually, so the video review tool, we've been working on inter-rater reliability. And so we're actually looking at our active trauma resuscitations in the trauma bay, gathering data. So we have a pre-intervention set, and that's before we did any multidisciplinary simulations, lead floor indicators or anything. And we're finessing the tool a little bit. That's one of the things that's also taken a long time in development, is getting everyone to agree on and be trained on the video review tool and then actually use it. So there's all these great tools that are out there, but a lot of them are very complicated. And so asking busy trauma attendings to go through and do these assessments has been challenging. So we've created a way to really pipeline it to the really important points, things that are easy to identify. So now we're working on completing the inter-rater reliability component and looking at the post-intervention. And so that'll give us some information. We don't have exact outcomes in terms of time to CT scan time. At that point in time, once we get to that level of granularity, I'm hoping we have more information. We also have an AI component to the video software that my chair is very strongly encouraging me to learn how to use. And we'll see, it could be great or it could be like a total flop. We'll see how that ends up going. But yes, we are doing pre and post intervention with video surveys with the tool. And then the outcomes of the intervention. So we clearly demonstrated the benefit of simulation-based education for the trauma team training with a growing disciplinary trauma simulation curriculum. We've had great strides in improved working relationships between emergency medicine and surgery residents, as well as with nursing. And I think that in and of itself has been a huge accomplishment, just to see everyone working better together, getting along, less fighting over procedures. The traumas flow better with less disruptions. Although we still have quite a ways to go. It's none of this is perfect. Using the tool, the video review tool for simulation can help guide those areas, not only for simulations, but also in the actual traumas. So I'll quickly with pitfalls, I think multi-specialty buy-in is a challenge that you're going to find no matter where you go. One of the struggles we have particularly had in our institution is getting the nursing, not that they don't buy in and think that it's important, but getting the nursing time. It's easier to get emergency medicine residents and surgery residents to have dedicated time. We have a great support with our respiratory therapists, and they've started using this as a continuing medical education tool, so they get validation that way. We're working into building, basically it's going to be a trauma team leader nursing program. And I think they're going to be required to do this to be part of the program. And I think that's going to bring a little bit more continuity and help from supporting aspects. Simulation resources, again, everyone has a wide range of simulation resources. And so that can be challenging, but there's lots of ways to overcome and still be able to successfully do the team training. Technological issues. So we've had days where everything's set up, everything looks beautiful, and then learning space is broken. So my mannequins aren't working, nothing's working, and it turns back into, here's a low fidelity setting, this is what we're going to do. And you just learn how to be flexible and adjust. Learner expectations. This is another pitfall. If you don't identify clear learner expectations, then they go into these scenarios thinking, I don't know, am I worried? Am I making the right decision? Oh my God, they have a gunshot wound to the neck and they're freaking out about that. And you're like, no, let's focus on primary survey, team communication. That's the focus here. Again, fidelity of the simulation. So this actually could be challenging because the higher fidelity, the more you notice gaps and issues. If we're running and 3 of the members have, very clear expectations and it takes the whole time to intubate this, that, and the other, but then you have nursing that I'm just verbalizing, gave Versa, gave this, and doesn't represent what it really looks like in going and getting the drugs, pulling them up, administering the drugs. So that's been a really important aspect to consider. And then obviously evaluation and assessment tools are very important. So ways to address the barriers. I'm running over. All right. Basically, interdisciplinary collaboration has been a huge aspect. Noting variable range of simulation resources, and then flexibility in curriculum and adjustment. I'm going to give you guys my information right now. So if you send me an email, I can give you all of the stuff. I can give you the PowerPoint. And if you have any other information that you want, I can give you some example, like the super detailed simulation, basically structured for the simulation center and everything else. So thank you guys very much. I know, right? Or sit them up. You're like, they're gurgling and choking on their own blood. Oh,